All right, we'll get started today. I want to thank everyone for joining me today, talking about blood flow restriction for this month's webinar. Any questions you may have, you can use your chat function and it will pop up on my screen and I'll try to answer all the questions that you may have. You can stop me anytime during this presentation and I will answer your questions as best as I can. So let's get started with our presentation here. All right, so today we're going to be talking about blood flow restriction training. Specifically, we'll talk about the introduction, what it is, kind of where it came from, what's evolved into. We'll talk about the science, really the science, the basic science behind the benefits of blood flow restriction training. When it comes to strength and hypertrophy, we'll also talk about the metabolite theory and different metabolites within our body, lactate, some metabolites with muscle activation and with growth hormone. And we'll also talk about the safety. Is it safe to use blood flow restriction training? I think I'm seeing more and more of this coming out in more gyms, trainers, and physical therapy clinics using this technique. And is it safe? And we'll kind of summarize everything in a take-home message, try to synthesize everything and take the pearls out of this. Hopefully you can take at least something out of this and be a little more educated on blood flow restriction training and see if that's right for you and if it is an option that your physical therapist offers you, if it is a good choice for you. So we'll get into it. So what is blood flow restriction training? Well, it's a method of partially restricting arterial inflow and close to fully restricting venous outflow in working musculature during an exercise. So the history of BFR training dates back to Dr. Yoshiaki Sato in Japan, and he called it Kaatsu training. And he achieved blood flow restriction by a tourniquet. And Kaatsu training means training with added pressure. And this has now kind of evolved and turned into something called BFR training. And now it's used, we use a pneumatic tourniquet that, like a blood pressure cuff that you will see at a hospital. We use something like that to restrict blood flow. So the technique that we use nowadays is a pneumatic tourniquet that involves applying an external pressure, typically a tourniquet cuff on the proximal part of the limb. So if it's the shoulder, just really up in the proximal shoulder, or the hip, very close to the hip joint. And that cuff, when inflated, results in pressure underneath it. So that will restrict arterial blood flow distal to the cuff. So anything past the cuff, it will restrict the arterial blood flow, but more so it restricts the venous blood flow back under the cuff. And that impedes with venous return from your extremities, hands, feet, thigh, depending on where the cuff is. And compression of the vasculature proximal to the skeletal muscle results in decreased oxygen supply. We call that hypoxia within the muscle tissue. And that causes a lot of different physiological responses within our body. And with that, we have decreased blood flow back to the heart, and almost blood pooling within the capillaries distal, so away from the cuff. And that you'll see with blood flow restriction training is that limb may turn red, and it's like gorging with blood. And this is dictated by the level of the pressure. So if the cuff pressure is greater, there's more blood flow being pooled within that limb. So it's more red, and you'll feel it being tighter or more full, that limb. And in this condition, contractions of that working muscle is performed right beneath the cuff. So tourniquet, increased pressure, decreased blood flow back to the heart, doesn't really affect the arterial blood flow going into the working muscle. And in that condition, you're basically contracting that muscle. And that is the basic technique of blood flow restriction training. And we will talk about what is happening with blood flow restriction in terms of the physiology. So strength and hypertrophy. According to the American College of Sports Medicine, we can optimize muscular strength and hypertrophy through moderate to high intensities of resistance exercise that utilize 8 to 10 upper and lower body exercises. And these exercises should target major muscle groups 2 to 3 days every week in training intensities of more than 65% of the subject's 1 rep max repetition. So if a person can do 1 rep of 100 pounds, and that's their maximum effort, so about 65 pounds is 65% of their 1 rep max. So when one would have to do that much weight 2 to 3 times every week, 2 to 3 days out of the week, in order to get hypertrophy and strength gains. And this follows the mechanical tension model of training that sufficient load must be placed on muscle to induce adaptive changes. Dr. Ron Meyer of Michigan State University states there is one issue which is applied to all exercise physiologists and molecular biologists, and they have all agreed that in order to obtain substantial hypertrophy from resistance training program, the target muscles must be subjected to substantially increased load. We need load to increase strength and hypertrophy. That is why the ACSM, the American College of Sports Medicine, recommends that during resistance training, the load should exceed 70% of the 1 rep max in order for hypertrophy. But unfortunately, the elderly people or people rehabilitating from an injury may not be able to tolerate these loads, which can limit their ability to have adequate strength and hypertrophy responses. It's hard for them to get 60 to 70% of their 1 rep max repetition because of an injury or because of age. So Dr. Ron Meyer says this, and blood flow restriction training in which a tourniquet is used can block that blood flow and has demonstrated strength and hypertrophy gains compared to controls. So we will look at some figures, we'll look at some research on how that is. So strength and hypertrophy. For instance, in a study that compared low intensity exercise to low intensity exercise with BFR, only the group using a tourniquet demonstrated a significant increase in muscle cross-sectional area and strength of the thigh. So here's the cross-sectional area, how big that muscle is if you were to take a slice of it. So BFR versus a controlled group, and this is 20% of their 1 rep max after 8 weeks of leg extensions. Control group did that 20%, but without the BFR cuff, and the BFR group did it, and this is their percent change in their cross-section area, how big that muscle got. And here's strength. So BFR versus controlled, same thing. Controlled, their strength increased a very small amount, and then a significant difference with the BFR. The cross-sectional area increase in the size of the knee muscle was 10% higher, as you can see in that figure, and the leg extension strength increased about 9.3% compared to control groups. So we can see that strength and hypertrophy both went up with BFR training. And here's a couple of more graphs here. High intensity training, so that's the HIIT versus BFR versus low intensity training. And they used for this, BFR is 30% of their 1 rep max. The low intensity training also used 30% of their 1 rep max, and the high intensity training used 80%, the kind of the traditional 80% of their 1 rep max. And they demonstrated, as you can see in this graph, very similar. The BFR group and the HIIT group showed very similar results with cross-sectional area of the biceps brachialis, which is part of the biceps, and the triceps. So both were significantly higher than the low intensity group. This is a gray area here. And also, if you can see in the strength for elbow flexors of the biceps, here's the BFR group, the control group, which is nothing, and then the high intensity group. So very similar between the BFR group and the high intensity group in terms of strength of the elbow flexors, which mainly are the biceps. So we can see from this study that strength and hypertrophy compared to HIIT group, which again was 80% of their 1 rep max, was very similar, only using 30% with a tourniquet. From this and other large bodies of evidence, it's apparent that the combination of vascular occlusion with low-level exercise is the key, can induce strength and hypertrophy response. So as we're going back to injury and maybe old age, one might not be able to do 80% of the 1 rep max, but we're seeing the same, very similar strength and hypertrophy gains with someone doing the same exercise at a very, very low intensity that is tolerable for that person. The exact mechanisms for these adaptations to BFR and exercise are not completely and fully understood. A lot of research is still being done. And one likely mechanism is the Metabolite Theory of muscle strength and hypertrophy, which researchers are just recently beginning to understand. The increase in metabolic byproducts from anaerobic metabolism seems to play as a powerful role in muscle physiology as mechanical load. So it's a very similar response that we are seeing with blood flow restriction training and traditional weight training without the load. So in a kind of a safer environment. So let's look at the metabolite theory of blood flow restriction. We have slow and fast twitch muscles. And as you can see, long distance running is a slow twitch. It's more aerobic. See the colors of these muscle fibers are redder, more blood flow. And then we get middle distance. You're starting to see a little bit more of these type 2 fibers, these fast twitch fibers. And then we see sprinting, which is a high intensity, very burst exercise that we're seeing low muscle fibers of type 1 and more of these type 2 fibers. And this is very typical of exercises, long distance, more endurance, and then more explosive like sprints. And blood flow restriction training follows many of the same physiological principles as traditional high load strength training. However, there's an important difference. High load training uses the mechanical tension across the muscle to recruit higher order motor units, which are the fast twitch muscles. This is the size principle of muscle fiber activation. Muscle is metabolically expensive, and our body has to adapt to use the most efficient means to complete a task. We have multiple checks and balances within our muscle metabolic system to limit hypertrophy, and lifting heavy loads or doing powerful activities such as sprinting forces our bodies to switch from these slow twitch fibers into more fast twitch anaerobic, less oxygen fibers. And anaerobic metabolism produces very strong muscle contractions. It's very short-lived. There's not a lot of energy for that, and creates a lot of byproduct. You get these explosive contractions that uses a lot of resources, and that gives off a lot of waste, a lot of byproducts. The byproduct of this action, these muscle contractions, is lactate and hydrogen ions. And that's when you feel the burn. When you're working out and you feel the burning of the muscle, that's the buildup of these lactate and hydrogen ions. And we're going to talk about more about this and why that's important with BFR. This burn that you feel in the muscle is not muscle damage. It is the acidic environment that is being created within the muscle. But a lot of these powerful muscle contractions do cause damage to the muscle fibers. And this is why you cannot do heavy bench press every day in the gym, despite most people trying to do that. So, or squatting or deadlifting, these, you can't do them every day. You're just too sore. And that is because of some muscle damage that is happening within the muscle fibers. The mechanical tension theory was initially understood through lab studies that simply attached a weight to a bird wing and allowed it to hang for several days. The tension across the muscle and subsequent muscle damage created a hypertrophy effect from growth factors that were being released. So they just hung a muscle. They didn't really contract the muscle. They just basically damaged the muscles of the bird. And then when that muscle healed, it healed to become bigger because of these growth factors that were being released while the muscle was being basically damaged. So it wasn't an active contraction. It was more of a passive, let the muscle tension increase and start to tear a little bit. And that tearing process became hypertrophy when it healed. So let's talk about these byproducts of lactic acid. So this lactic acid production, blood flow restriction training helps tap into these fast twitch fibers, these type 2 fibers, recruitment, but it doesn't follow the mechanical tension model. You don't need all that tension because the loads are very, very low. You need high tension to engage these fast twitch muscles. We just talked about the recruitment. So slow twitch, not a lot of muscle recruitment. Fast twitch, you want a lot of muscle recruitment, but BFR doesn't follow that model. With blood flow restriction, we limit the oxygen supply to working muscle, which essentially forces it to switch from aerobic to anaerobic metabolism. So the oxygen supply to the muscle is being choked, literally, physically, by a cuff. So the muscles aren't using oxygen as a fuel to contract the muscles. And we call it an anaerobic type contraction, which is more of that type 2, really quick, really fast twitch muscles. The same byproduct is still lactic acid production within the muscle. So when a person performs VFR exercise, they will definitely feel that lactic burn. It's like, wow, I feel like I'm doing 500 of this. You know, they feel this burn. And here's a model of a lactic acid molecule. So the Cori cycle is, aka the lactic acid cycle, is a metabolic pathway where lactate is produced by anaerobic metabolism. A byproduct of the Cori cycle is lactic acid. The net result is one glucose molecule creating 2 lactate byproducts. The lactate is moved out of the muscle and into the liver, where it undergoes glucogenesis, the creation of glucose, which is the conversion of lactate to glucose, or it is used to replenish depleted glycogen stores within the muscle. As mentioned, heavy loads or powerful contractions utilize this Cori cycle. If BFR truly activates this cycle, we should see a subsequent rise in lactate, right? So if the muscle is contracting, and you can see this diagram here, the muscle, the glucose is being used to create energy, and that causes a muscle contraction. That's the Krebs cycle. I think people have heard of the Krebs cycle before. And you get some ATP, which is energy, and you get pyruvate as one of the byproducts, and pyruvate turns into lactate. This lactate circulates, goes into our liver, you add in 2 pyruvate and becomes glucose with energy, and that glucose goes back to the working muscles. So with BFR, you should see this lactate build up within the muscle. The more lactate buildup, you know that this Cori cycle, this whole cycle is happening with more lactate buildup within the muscle. And we'll see if that is true or not. So here's BFR versus control with lactate accumulation within the working muscle. So BFR is 20% of their 1 rep max, control group, 20% of their 1 rep max. So very, very, very light loads. And what are we seeing here? We see a spike post exercise with this BFR group. Multiple studies have measured blood lactate after BFR has been demonstrated a subsequent rise in lactate. For comparing 1 rep, so 20% of 1 rep max, low load exercise with and without a tourniquet, only the tourniquet group demonstrated a significant rise in lactate. So no cuff, very little to no change over time. With a cuff, huge spike in this lactate buildup within the blood. How about this here? Blood lactate, BFR exercise versus that high intensity interval training, high intensity training, and then low intensity exercise. What are we seeing with the blood lactate? Very similar response from BFR with the high intensity training. Significant difference. That's what these stars are for. Poton, I don't know if you're saying his name, Poton and friends demonstrated that the levels of blood lactate accumulation were similar between BFR and exercise at low loads. Again, this is 20% of their 1 rep max, and high intensity training, and they did 80% of their 1 rep max. A control group performed low exercise at 20% of their 1 rep max without BFR, and no significant rise in their lactate production. So 80% 1 rep max, high intensity training, very traditional, and then low intensity with the BFR, almost similar response when it comes to blood lactate. So here's an interesting study. This study showed that the largest lactate accumulation was the 40% of the 1 rep max group. These authors speculated that the high intensity repetitions, which is the 80% of 1 rep max, were strong enough to cause a muscle pumping effect and pushed out metabolites such as lactate. This has also been observed in another study that demonstrated no additional benefit of BFR during moderate load and high load resistance exercise on measures of muscle strength and size. In fact, a recent meta-analysis found that loads of 15 to 30% of 1 rep max had the largest effect on muscle size and strength when employing BFR. So what does that mean? Utilizing BFR and doing low intensity, not medium, not high intensity exercise appears to augment lactate production in the working muscle. The most obvious explanation for this is the hypoxic, the low oxygen state created by the tourniquet and the activation of the fast twitch, fast glycolytic fibers, even though the loads are light, which is atypical, different from our traditional weightlifting. However, other than demonstrating that we are in the Cori cycle using the lactate, why would we care about increasing lactate? It burns, it doesn't feel great. Why is that important? And one reason is motor unit recruitment. We talked about motor units, how we go from slow twitch to small motor units to fast twitch, really big, large motor units. So there might be a reason why there's such a lactate buildup with motor unit recruitment. So muscle activation. Interestingly, the increase in lactate may also drive an increase in muscle activation, and that is measured with an EMG. So EMG activity measures muscle activation. The higher the EMG, the more that muscle is being engaged by the nerves. So as lactate builds up in the muscle, it inhibits surrounding contraction of working muscle fibers, and consequently, additional motor units need to be recruited in order to maintain force production. So it's like sending out a deny or stop signal around its surrounding. So in order to continue to contract that muscle, even if it's low load, it has to recruit all the muscles in the neighborhood, everything, to try to really contract that muscle. This essentially follows the size principle that is in work under heavy load. So it's the same as if I were to lift heavy. If I were to lift very small weights, only small motor units. I don't need a lot of motor units to lift a small weight. As the weight gets heavier, my body's like, oh, I have to recruit more muscles to lift this load. So it starts to recruit more and more and more muscles as the load gets heavier. And that's the same thing that they are seeing with BFR group. So you see this graph here, as the lactate is building up, the muscle activity also goes up. This is almost a linear progression here. The more the lactate, more the muscle activation. So in summary, it also makes sense that the longer you exercise in a hypoxic, low oxygen state, there is less blood flow to the working muscle due to the tourniquet. The more fast twitch fibers will need to be activated. If there is insufficient oxygen supply, but the exercise is still ongoing, then the muscle is forced to recruit more motor units. I hope that makes sense for everyone. So in a hypoxic state, we're going to start to use these fast twitch anaerobic type muscles, right? So as you have a tourniquet, less blood flow, less oxygen to that muscle, we start to use anaerobic pathways to muscle contraction. That's the fast twitch fibers. If there is less oxygen and that exercise is still going, I'm still pumping, then I need to use more muscles. Right? I can't just use these small muscle groups. I need to use large motor units and recruit more muscles to get that activity, that exercise completed. So we'll talk about growth hormone next. So we talked about lactate and the Cori cycle and motor unit recruitment. What about growth hormone? An accumulation of lactate and hydrogen ions within the muscles, and we talked about this earlier, in an augmented growth hormone release. This causes an acidic environment, right? The ions are positive, so it causes a lot of, it's an acidic environment. This has been confirmed in experience where sodium bicarbonate, which is a base, an alkaline product that can neutralize acidity ingested before exercise, decreased growth hormone release after intense cycle sprinting compared to work-matched controls. So the more lactate, the more hydrogen ions, the more acidic the environment is, the more growth hormone is released, right? And the same is true with the opposite. If it's more basic environment, then less growth hormone is released, even with the same type of exercise, same type of workload. So there's the accumulation of lactate from the BFR. We already talked about that. Translate into increased growth hormone secretion. So let's look at some studies that kind of studied that. So growth hormone response, effects of BFR with exercise, without exercise, and exercise alone. So this is just a tourniquet. Didn't do anything. They just put a tourniquet on, didn't do any muscle contraction. Low load exercise and BFR and exercise. And so from the available evidence, it certainly appears that it does. This group found a large and significant rise in growth hormone after performing low intensity BFR for approximately 10 minutes of exercise, 10 minutes of exercise. A second group performing low intensity exercise without occlusion, and a third group that just wore a tourniquet, no significant rise in growth hormone. As we talked about earlier, just wearing a tourniquet but not exercising does not produce a growth hormone response. And this highlights the combined effect of using a tourniquet with low-level exercise to produce a systemic response. Growth hormone comes from our brainstem. It is a systemic response. So it wasn't the tourniquet that made the rise in lactate. It was the tourniquet with the muscle contraction that caused a rise in lactate, which in turn caused a rise in growth hormone. And I think everyone knows the benefits of growth hormone. I mean, this is a huge difference right here. And here's just a low load, no tourniquet, and just the same motion, same load. So growth hormone response with BFR versus control, they specifically studied this. In this study, the rise in growth hormone was 290% higher than baseline measurements. And it's a almost 2 times higher than what has been reported for high intensity training. So 80% of their 1 rep max. A control group that performed the exact same exercise, exact same load without a tourniquet did not demonstrate a significant change. This rise in growth hormone was over twice as high in the BFR group compared to the controls. You can see it here. Here's the BFR group and the low load exercise group without the tourniquet. Look at this spike after about 15 minutes with the tourniquet on and exercise, the spike in growth hormone. And here it is with the low load exercise group. Here's the lactate response, almost identical here. Spike in lactate at almost the same time, a little bit before, but very similar time, and low load exercise, pretty much steady throughout. So we do get the systemic response. Increased lactate happened first, body responds, increased growth hormone release. So this also kind of confirms that increased lactate, also your body responds with increased growth hormones. So these and other research supports the role of BFR to increase growth hormone levels even with low load exercises. But does it really matter that you raise growth hormone levels for rehabilitation? Perhaps the name growth combined with hormone automatically leads to assumption that it is involved in muscle hypertrophy. So we think about growth hormone and that will increase our muscle size, it will increase our muscle capacity. But contrary to that popular opinion, exogenous administration, so injection of growth hormone, may not lead to an increase in protein synthesis and subsequent muscle hypertrophy. So this study found that if you administered growth hormone, it didn't necessarily lead to more protein synthesis and more muscle hypertrophy. In another double-blind study, 47 healthy elderly men and women received either placebo or growth hormone for a 12-week period. No difference in muscle strength, muscle power, and muscle hypertrophy was observed. So growth hormone by itself didn't do anything. It's the same as placebo. Didn't increase their strength, didn't increase their power, didn't increase the size of their muscles. Even though it's widely believed that growth hormone plays a role in muscle anabolism and athletic performance, a recent systematic review found no effect of human growth hormone on athletic performance. So if you just take growth hormone, they're finding that it doesn't do anything. You have to actually work and benefit from that growth hormone. So we do know that exercise is one of the most potent physiological stimulators of growth hormone secretion. There have been many studies that showed exercise and post-exercise, one's growth hormone spikes, and that's been proven. So they know that it does. So growth hormone must have a role in helping the body after exercise. There's a high correlation between exercise and the secretion of growth hormone. So we must deduce that growth hormone and exercise are somewhat related. We can now understand that the role is recovery, primarily through increased collagen synthesis. So we'll talk about collagen synthesis and its role with growth hormone. Growth hormone and collagen synthesis. Recent study demonstrated that growth hormone played a direct role in increased collagen synthesis after exercise. In this study, subjects took exogenous growth hormone, so they injected growth hormone for 14 days and demonstrated an almost fourfold, it's a 3.9-fold increase in tendon mRNA expression and 5.8-fold increase in muscle collagen synthesis. Muscle protein synthesis did not change. So with this exogenous growth hormone, 3.9-fold increase in collagen, muscle tendon mRNA expression, and 5.8-fold increase in muscle collagen synthesis. So it appears that the role of growth hormone is to protect our tendon and muscle collagen structure after exercise. So the correlation of increased growth hormone release as the exercise intensity increases may be the body's protective response to help our tendons and other collagen-rich matrix recover. So that soreness that you get after exercise, growth hormone release may be helping with repairing the tendon, the muscle collagen that has been broken down during that exercise. So more evidence for the effect of growth hormone on tendon structure was recently revealed in a study that immobilized one leg of elderly men for 2 weeks, then followed this up with 6 weeks of rehabilitation. One group received growth hormone supplementation and the control group received a placebo. The growth hormone group exhibited increased tendon stiffness and improved collagen synthesis compared to the control. So they did the exact same thing for 6 weeks. One was taking growth hormones and the other group was not. So the authors concluded that in elderly humans, growth hormone seems to have a matrix stabilizing effect during inactivity and rehabilitation by stimulating collagen expression in the musculotendinous tissue and increasing tendon cross-sectional area and stiffness. So they're showing that growth hormone may not be making the muscle bigger, but protecting the tendon and the collagen around the muscle and improving its repair, quickly making the repair. So with BFR, you can induce increased growth hormone production and potential healing through collagen synthesis, right? So we saw the lactate goes up, growth hormone goes up, and this is going to promote this potential healing of collagen. It is clear that if we can increase lactate accumulation, there will be an accompanying rise in growth hormone. By using a tourniquet and safe low loads, we can manipulate the healing environment around injured tendon, muscle, and bone through increased collagen synthesis. This is important not only for collagen, ligament, and bone, but also for the collagen matrix that supports muscle and is often disrupted after an injury. You get injury, you get acute itis, muscle, tendonitis, inflammation, and everything just kind of is mangled. So this is important to repair all that tissue and putting it together with rehabilitation. Additionally, we can reduce stress on injured soft tissues and joints and bones using low loads to produce lactate with the accompanying rise in growth hormone. So it's almost the same, if not higher, to the high intensity training, the rise in growth hormones. And we saw the body's reaction to more and more strenuous exercise is to increase growth hormone in preparation for the subsequent collagen breakdown. The low loads associated with BFR do not cause this breakdown, and you end with a positive collagen turnover. So the low loads that we use with BFR, and we were using from these studies, 20 to 30% of their 1 rep max, doesn't cause collagen breakdown, doesn't cause that soreness that you get from high intensity, which is 80% of your 1 rep max. It does cause an increase in lactate. It does cause an increase in growth hormone without the breakdown of collagen. So that's why we end up with a positive collagen turnover. It's just making more collagen, stronger tissue, stronger tendons without the breakdown part of it. So it sounds all good and grand, but what about its safety? People are really concerned about thrombus, which is blood clots, basically. And contrary to what people believe, tourniquets used for short durations do not seem to pose an increased thrombus risk. And if you saw our previous studies, you get the most effect about 10 minutes into BFR. And with that short amount of time, it doesn't pose an increased risk for thrombus, the blood clot. BFR studies that look specifically at potential markers of thrombus formation have not found any. This study in 2010 found no increase in markers of thrombin generation, which is a hormone to make thrombus, or intravascular clot formation after BFR with exercise. Conclusion, BFR is safe. All right. So we always have with exercise, consult your physician before starting an exercise program. So every piece of exercise equipment has that. So exercise in and of itself poses some risks, but with BFR training and these very, very low loads, it doesn't have any risk for, at least for thrombus. What about other parts of exercise? Exercise is a stressful event, right? You start to sweat, you're huffing and puffing. And for all of the health benefits that come from adaptations to chronic exercise, the risks, both actually and chronically, can be ignored. There are more benefits than risks to exercise. As we talked about previously, ACSM guidelines suggest loads of 75 to 85% of an individual's 1 rep max to induce strength and hypertrophy. A study that we'll look at have reported elevations in blood pressure as high as 480 over 350. If you recall, 120 over 80 is kind of a healthy individual. And when exercising at this 80 to 100% of their 1 rep max, their blood pressure can go up to 480 to 350, 480 over 350. So really high blood pressure. Additionally, heart rate reaches values of 170 beats per minute. It is concluded that mechanical pressure on the blood vessels while lifting heavy loads elicits a potent pressure and Valsalva response to produce extreme elevations in blood pressure. Valsalva response is, for those of you that weight lift, is like the holding the breath and pushing through. That increases blood pressure, and afterwards your heart rate will go up too. But in contrast to heavy lifting, BFR at 20% of 1 rep max to a free flow work match group found slightly higher values in BFR group versus control group. So if we look at this study here, we have a BFR versus control group. Control group still doing the 20% 1 rep max. BFR also doing the 20% 1 rep max, but with a tourniquet. So the blood pressure, systolic is the top number here, 180 over 100 with the BFR group, and the control group without the tourniquet, about 150 over 100. Not much difference with blood pressure. How about heart rate? BFR versus control group. 107 and 100, a little under 100. So heart rate doesn't go up too much either. So the cardiac response is very minimal with the BFR compared to non-BFR, no tourniquet, with the same amount of workload. And the authors conclude that these values are all well below changes seen within traditional high intensity training. So here we have high intensity training into the mix versus BFR versus control group. So BFR control group, we saw very similar response. High intensity training, here's that 480 over 350. How about heart rate? High intensity BFR control. BFR control we saw previously, very minimal differences, high intensity way up. BFR is not a cardiovascular exercise modality. So we're just talking about safety. Is it safe to use with elderly? Is it going to spike up their blood pressure? Is it going to spike up their heart rate? How about somebody with a pacemaker? You know, we have to be worried, or vascular damage, diabetes. We have to be concerned about their vascular integrity and also cardiac response. But as you can see here, cardiac response, BFR is safe. It's almost the same as without the cuff in terms of cardiac response. So safety, BFR poses no risk of increasing clot formation. Cardiac response using BFR is typical of regular exercise at that same intensity. So the conclusion with safety, BFR is pretty safe to use. So what is a take-home message from kind of our lecture here today? BFR can help to improve strength and hypertrophy of muscle without the traditional heavy load, making it a safer option when rehabilitating injured tissue. It does this by increasing lactate buildup and utilizing the Cori cycle, which improves muscle activation. You're using more of that working muscle without the load. BFR also increases growth hormone. With the lactate buildup, growth hormone is also being secreted at a higher rate, which may have a protective role in ligaments, tendons, and muscles. It is also very safe to use. We saw that with thrombus, with clot formation, and we saw that with our cardiac response. So it's very safe to use. And that is BFR. So here's all the references. If anyone wishes to see any of these articles, you can email me or call directly. Any questions, you can please put it in the chat room. So I don't think there are any questions here. So I want to thank everyone for joining me today in this talk about BFR. If I see some familiar names in the attendees, if you wish to try out BFR, we have them at the Deerfield and Lincoln Park locations. So anyone rehabilitating an injury or want to improve some fast twitch muscle fiber activation engagement, improve their strength and hypertrophy, but they're unable to lift heavy, I think BFR is a good option for you. So consult with your physical therapist. and see if that is a good modality, good intervention for you. So if you have any questions, you can please put it in the chat room. If not, it was really good to spend time with you guys. If you have any questions, you can email me at jkim@bereact.com or call our clinics. Our website is bereact.com. We have a question here. So a question is, would this be implemented instead of a full body resistance routine or isolate one specific injured part of the body? That's a great question. You can use this bilaterally. So you can use this on both limbs at the same time and do a full body resistance routine. In a rehabilitation setting like ours, we want to isolate a specific injured body part. So if someone post-op knee, a lot of times their quads become weak and shut down after surgery. And we want to really focus on quad engagement and increasing the strength of their quads. If you're fresh post-op, we can't squat, we can't do deadlifts, we can't do a lot of leg presses, leg extensions. We can't do those traditional lifts to increase strength, especially not at 80% their 1 rep max. We can't do that. What we can do is probably quad contractions, quad sets, low quad engagement in supine or in sitting with the BFR tourniquet on, and cause the same response, increase their strength and hypertrophy with the same exercise and the same response. So it can be used as full body, but in our setting, we really don't. We use it for specific muscles, to strengthen basically specific muscles. So it's a good question. There are people that use it with biking. They put it on both legs and they'll bike on it. And that'll work both their limbs. And that's probably really intense when they bike with the BFR cuffs on their legs. So it's gonna be a really intense exercise, but you can use it. But again, we talked about it today, is there's a systemic response to it. Your growth hormone goes up regardless of if you're doing a full body exercise or an isolated muscle contraction. Your growth hormone rises, and that's a systemic response. So that's a good question. So if there aren't any questions, I don't see any more. We will end our discussion here. Thank you all for joining me today. Hope you found at least one pearl from this presentation and one take home that you can use and educate your family and friends on this. Again, if you have any questions, please reach out to me at jkim@bereact.com, or we can call the Deerfield office if you have any specific questions. It's great to see everyone, some familiar names, and I hope to see you soon. See you guys.